I'm Darren Mays from the Ohio State University Comprehensive Cancer Center. I'm happy to have this opportunity to talk with you today about cancer prevention with mobile messaging, including 2 examples from my research on melanoma prevention and tobacco control. I have no relevant financial relationships within the past 24 months to disclose. To start off, I want to give a disclaimer that the concept of leveraging mobile technology for health promotion and disease prevention is not a new idea. For example, the National Institutes of Health convened the first mobile or MHealth summit in 2009 to explore the use of mobile technologies to improve public health in the US and around the world. But I want to focus us on MHealth for cancer prevention with this quote from a recent paper by Judith Prochaska and others. The boom in MHealth has been made possible by high penetration of internet access and increased use of smartphones. MHealth technologies offer the ability to scale and engage entire populations, develop supported social networks, connect patients and providers, encourage adherence with cancer care, and collect vast quantities of data for advancing cancer research. In other words, these devices we carry in our pockets everywhere are extremely powerful tools for cancer prevention. So what makes this the case? These are data from the Pew Research Center on mobile phone ownership among US adults since 2004. The blue line displays the increase over time in any mobile phone ownership, and as you can see, now it's virtually all US adults that own a mobile phone. The yellow line displays smartphone ownership, that is Android and iPhone type devices, which has accelerated over the past decade to about 80% of US adults today. The table on the right breaks these trends out by social demographic characteristics. And I want to focus on a couple of these examples to highlight where there are notable differences in technology ownership. For example, by age, older adults are less likely to own smartphones than younger adults. And by geography, those residing in rural areas are less likely to own a smartphone than those in urban and suburban areas. I'll come back to this a bit later as we revisit this topic in a subsequent slide. When we think of interventions for cancer prevention, a relatively straightforward way of considering their impact in the population is through this formula from the RE-AIM framework, where reach, or the number of people in the population affected, times the intervention's efficacy equates to the impact in the target population. From this perspective, MHealth interventions for cancer prevention are positioned for very high impact because it's a technology through which effective interventions can reach so many. Another recent trend I'd like to highlight, pointing to the importance of MHealth interventions, comes from the healthcare sector. The past 14 months have been a unique experience, to put it lightly, because of living in the COVID pandemic. In our day-to-day lives, we've shifted how we work, how we monitor kids at school, and many other activities to technology-mediated communication. This figure from The Economist provides a bigger picture perspective in related shifts in the industry. Global digital health revenues from telemedicine, online pharmacies, wearable devices, and so on will rise from $350 billion last year in 2019 to more than $600 billion in 2024. The groundwork for what looks poised to be the next trillion-dollar business has been accelerated by the COVID-19 pandemic. I highlight this because despite long-standing interest in MHealth technology for health promotion and disease prevention, one potentially positive impact of the pandemic may be an acceleration in interest in developing solutions such as MHealth interventions for cancer prevention. So with that context, I'd like to highlight 2 examples of MHealth interventions from my own research in the area of melanoma prevention focused on indoor tanning and tobacco use focused on water pipe or hookah tobacco smoking. And at first glance, these may seem like very different behaviors, but there are in fact several similarities that lend themselves to the MHealth intervention approaches that we're studying. Both are established risk factors for cancer in ultraviolet radiation exposure and exposure to combustible tobacco smoking. Both are entirely preventable. Removing the exposure by helping people change their behavior reduces the cancer risk. Both are behaviors that tend to emerge or onset early in life, that is, during adolescence and young adulthood. Both are addictive behaviors. Tobacco use, this is firmly established with nicotine as the addictive substance in tobacco. Indoor tanning, this is less well known, but there's a growing body of evidence indicating some young people become addicted to indoor tanning, and that's how my research approaches this problem. Both are behaviors where there's low motivation to change in young people. Both are also relatively infrequent behaviors. So when we think about something like cigarette smoking, which happens multiple times a day, indoor tanning and water pipe tobacco smoking are most typically weekly or monthly in frequency for young people. And both are behaviors where there's very little published intervention science. So we're starting from a fundamental point in the research and in terms of how we can intervene to prevent the cancer risks associated with these. So in the first example of our intervention research on indoor tanning that is supported by funding from the Prevent Cancer Foundation, our population is young adult women who meet research screening criteria for indoor tanning addiction. So this is a high-risk group from a behavior standpoint for melanoma and other forms of skin cancer. Our study design is a two-arm parallel group randomized controlled trial. We developed a mobile messaging intervention that's 4 weeks in duration, and during that time, participants receive text messages to their mobile phones on 2 days each week. This is in contrast to interventions, for example, for cigarette smoking, where it's much more typical to have multiple messages a day, for example. The content that we created for these messages, they're text messages, so just like text messages that you might receive or send to family or friends. In this case, we're sending content that's focused on communicating the risks of indoor tanning, because we know that that's an issue where awareness is low. And we're providing content to enhance their motivation and support quitting. All of this is tailored or personalized to their initial readiness to change when they start the intervention. The outcomes that we're measuring in this study, two of the outcomes are cessation, if they quit, and motivation to quit. And in this case, I'll be presenting data on our 4-week outcomes at the end of the intervention. This is an interim presentation of interim findings because we're about halfway to our recruitment goal. We'll have longer term outcomes at a later date. So in the table, this displays the proportion of participants reporting quitting indoor tanning at the 4-week follow-up in the control group and in the intervention group. This is not quite a statistically significant difference, but what we're seeing in this interim sample is about twice as many participants in the intervention group are reporting quitting compared to the control group. We also measured, as I mentioned, motivation to quit indoor tanning, which is shown in the figure. As you can see, the red line is the control group. There's essentially no change from the baseline to the follow-up, but in the intervention group, we see a significant change in motivation to quit from baseline to the follow-up time point. So these are positive signals in an interim analysis as we're continuing to recruit for this study that our intervention, our MHealth intervention, is having the intended impact on indoor tanning behavior. The second example from my research is focused on water pipe or hookah tobacco smoking cessation, and this is work that's funded by a grant from the National Cancer Institute. Our population in this case is young adults who are current hookah tobacco smokers. And our study design is a 3-arm parallel group randomized trial. In this case, we have a control group that's receiving no intervention, and we tested 2 versions of our mobile messaging intervention. The first is called an untailored version, and what that means is all of the participants get the same exact content. And the second is a tailored intervention. So in the tailored intervention, that content is personalized to data that we collect at baseline, as well as text message exchanges that happen with participants during the intervention itself. Like the tanning study that I gave as an example, this intervention is 6 weeks long, and we're delivering messages on 2 days a week during that time. The content is slightly different. In this case, we're using what's called mobile multimedia message service messages. In plain language, what that means is text and images. So like the photos or other pictures you may send and receive from family members and friends, in this case, we're sending intervention content communicating the risks of hookah tobacco smoking in both text and a visual. And we're also including content that is aimed at motivation enhancement to support quitting. Our primary outcome in this study, among other outcomes that we measured, was cessation at 6 months, and we measured this at interim time points as well. So these are our data on cessation at a 6-month follow-up, which we analyzed in 2 ways. We had great retention in this study. We retained 91% of our participants at the 6-month follow-up, but we still looked at the data to account for attrition in our analyses. So when we analyzed the available data, that is only the people who completed the follow-up, cessation was significantly higher in the tailored intervention arm at 49% versus the control, which was 29%. When we assumed that all of the people who were lost to follow-up had continued smoking, cessation was still significantly higher in the tailored intervention arm at 43% versus the control arm at 28%. So this is another example of an efficacious, from our trial, mobile messaging intervention, in this case for water pipe or hookah tobacco cessation. These 2 examples from my research are what I would call, from a technology standpoint, relatively straightforward MHealth interventions. That's not to say they weren't a lot of work to create, to conduct the trials, to test, but what I mean by that is we're relying on native messaging apps to send and receive text messages with participants in these interventions. We're not yet using things like mobile applications or other technology that are available through these devices to potentially promote behavior change. Thinking about the background that I presented on mobile phone ownership and trends and how we can maximize the potential impact for mobile interventions, I want to conclude with 2 points about what kind of science we still need moving forward. The first point I want to leave with is focusing on efficacy. So recall from the RE-AIM framework that reach times efficacy equals impact. We have high reach with mobile devices. We need efficacious interventions to create impact for the cancer prevention behaviors that we're targeting. The first quote here is from a recent Cochrane review of the evidence for MHealth smoking cessation interventions. And the authors concluded that there's moderate certainty of the benefit of text messaging interventions, but the evidence comparing smartphone apps with less intensive support was of very low certainty, and more randomized trials are needed to test these types of interventions. The second quote is from a recent study that reviewed content of applications that are available to consumers now through the App Store on iPhone devices, the Android Store for Android devices. And these authors concluded that the vast majority of the mobile applications for behavior change that are available to consumers included a limited number of techniques to promote sustained behavior change. Although some of this evidence is from studies for cigarette smoking cessation, I believe they hold true, the conclusions hold true for other cancer prevention domains as well. The science on efficacy needs to be better developed, and what is available to consumers, for example, through the App Store and the Android Store, is predominantly not evidence-based. The second point I want to leave you with is to focus on equity. And so recall the data that I showed initially, demonstrating that although mobile phones in general are used by nearly all US adults, there are still some gaps. For example, when we consider smartphone ownership by specific demographic groups. This speaks to the need to address disparities both in technology use and in cancer-related behaviors in the science. In a recent commentary on this issue, Huen and Vishwanath stated that just as robust clinical trial evidence is critically necessary, consideration of how MHealth technology can be adapted and strategically delivered to the most vulnerable patients is of equal value. So the question is, how can we design and deliver our MHealth and other digital interventions in a way that addresses ongoing cancer disparities? The second quote is an example of the conclusions from a recent analysis by Michael Amato and Amanda Graham at the Truth Initiative, an organization that's one of the leaders in digital smoking cessation interventions in the US. They examined in a recent study registration over time to their Become an X program, a digital smoking cessation program over several years, and found that smokers from non-metro or rural areas appeared to seek out and use digital cessation resources during this time, and attributed it to broadband availability and increasing smartphone use in those populations. To me, this is a great example of intervention reach in a community that's traditionally affected by cancer-related disparities in rural communities. We know they're affected by higher smoking rates and smoking-related cancer, yet this evidence shows that they are receptive to and proactively engaged with digital and MHealth interventions, demonstrating that they can be impactful for reducing cancer disparities if they're thoughtfully designed and distributed to reach such groups. So I encourage those of us who are working in this space or interested in this space to consider how our interventions can be designed to leverage the technology that meets the needs of the target populations in an optimal way to enhance the impact on cancer prevention outcomes. I will stop there. I thank you for your time, and I look forward to discussing any questions or comments you might have. Thank you.